asked her specifically, what makes you think that you were awake during your cardiac surgery? And she said, I distinctly remember the words cross clamp. And you do not, if any of you have seen open heart surgery, they cross clamp the aorta in order to stop blood flow while they're working on the heart and get them on the heart-lung machine. So yeah, she really was. But that's why, because she had such a tolerance to anything, to morphine, to any of the gases, and she was actually awake during. She said, I couldn't feel pain, which is good.
Yeah.
So that's another thing that we want to talk about when we're talking about dealing with not only procedural sedation, but any sedation in the ICU coupled with paralytics. How many of you have seen a patient that was under the influence of paralytics? Okay, why? Why were they under the influence of paralytics?
Or they would desaturate
They would desaturate.
when they would move, so they had to back up.
Okay, so just moving caused them to desaturate.
Yeah.
How come?
I think ARDS.
Classic. That's a classic. Yeah, symptom of ARDS. In the back, what was your what was the scenario for that you were talking about?
Organ surgery.
Ah, okay. Okay. So you already work in surgery. You've seen it. Okay. So let's talk a little bit about some of the things that we would. What are the procedures that we would sedate for? Somebody said, yeah.
When I was in the ED of Woodland, this kid came in and took a baseball pitch to the face, knocked out 4 of his teeth. We had sedated for that.
For a dental procedure or something like that.
Yes.
Okay. Yeah. Dislocations, reductions of dislocations, cardioversions, elective cardioversions. You want to have procedural sedation. I worked for 8 years at St. Joseph's in Stockton, and they'd always call RT, and I was a supervisor, so I always got called. And there was a group of cardiologists that did on their lunch hour did five elective cardioversions in a row. So it was like, okay, Versed, zap, Versed, zap, Versed, zap. And these patients would wake up and go, is the doctor going to be here? Sir, you're already done. You can put your clothes on and go home now. So yeah, it was kind of interesting. One of the things that was unfortunate was when you're looking at, and RTs may or may not be involved in this, but if you're looking at what agents are being used, be sure they have the right concentration. Years ago, Versed, everybody familiar with Versed? They know what it is? Midazolam? Okay, it is a anxiolytic typically, but it's used for sedation. So it was manufactured in 1 milligram per vial and 5 milligrams per vial. One was purple, one was green. So we were, as I said, we were doing this, Versed, zap with these elective cardioversions. We just had all these patients lined up in a bay, and we'd go to that person, and it was like a factory. Unfortunately, this one particular day, the nurse who was administering the sedation grabbed the 5 milligram vials, and so if we were giving 10, that would have been 50. So Romazicon. Everybody know what Romazicon is? Romazicon is a reversal agent for benzodiazepines. Yeah, it was a little interesting. The nurse was, she was really upset. She almost quit. But it woke us up to the fact that we can't be doing these procedures this fast. You have to be able to assess the patients. And these patients had end titles on, and no indication that they were, they just couldn't wake up. Fortunately, most of these patients were not COPD patients, so they didn't have a lot of those effects. So, what are some other things that we would we might sedate a patient for in a procedure? Yes. A bronch. Yeah, we could. You kind of want to do that. What do some of the opiates do for a reflexive cough? Suppresses it, right? Okay. What else? What else that you would give in a bronchoscopy? What else would you give to suppress the cough? How about xylocaine? Lidocaine? Topical lidocaine in the airway? Yeah. Personally, I've done 2,500 intubations in my career, and not once have I used paralytics. I used boatloads of lidocaine. A couple of reasons. One, it suppresses cardiac irritability, myocardial irritability. Number two, it suppresses a gag reflex, so you usually get pretty good a numbing effect. So that was lidocaine was a big. Anybody ever seen what was known as an LTA? It's a laryngotracheal administration device. It's a syringe. Remember the syringes that you screw together and you give them? Everybody seen that? Okay, same thing, but it's got a wand on it about this long. And you put this down the airway. It's loaded with 2% lidocaine. And you put this down the airway. It's got holes all the way down this wand, so it's like a sprinkler. You just put this down the airway, and go whoosh, and it numbs everything that it comes in contact with. So suppresses the gag reflex. Also, I asked for 50 milligrams of lidocaine. Anybody know what a rapid sequence induction is? You heard of that? An RSI? Okay, we're going to RSI this patient. Okay, well, why would you want to do that? I shy away from rapid sequence inductions unless it is emergent, and we do it routinely all the time. Why? Because it's easy. That's one of the biggest reasons I ask emergency room physicians, why do you use an RSI, rapid sequence induction? Because it's easy and I don't have time to wait around. Okay, well, that's unfortunate. But, because usually they'll use succinylcholine. Do you know what, heard of succinylcholine? What's the difference between succinylcholine and like Norcuron? Anybody know? I'm sorry? No reversal? Is that what you're saying?
Yeah.
Okay, one's non-depolarizing and one is depolarizing. What's the more dangerous one? Depolarizing, which is succinylcholine. You can have refractive tachycardia, all kinds of different complications. So I shy away from paralytics. And if you give a patient paralytics and you lose the airway, yeah, you're in trouble, because you might be facing a surgical airway, like a crike or something like that. I shy away from those things. So we've gone through most of the indications for procedural sedation in the procedures. How about sedation in the ICU? Why do we sedate our patients in the ICU? You can think of these things. Come on.
Ventilator to see.
Keep them comfortable. Here's the ICU nurse, and I don't want to smash ICU nurses, but that's the ICU nurse excuse. If I was a patient on this ventilator, I would not want to be awake, so I'm going to snow my patient. And this is 7:30 at night, and they're working nights, and they want to have a quiet night, so they'll sedate their patient all night. We have seen this in the past. Where I come from, Sutter Amador, we absolutely got away from that. We said, no, you can't do that. You follow the PAD guidelines and all the guidelines that we have put forth in the what is known as the ABCDE bundle. It's a bundle. If you haven't seen it yet, look it up. The ABCDE bundle is a protocol by which we can discontinue ventilation more readily and much more quickly. So the ABCDE bundle is part of the ICU liberation. There's a gentleman his name is Dr. Wes Ely, and Dr. Ely is kind of like the champion of preventing ICU delirium. That is the name of his website, icudelirium.com. And he has many articles on reasons not to sedate your patients. So be really judicious when you're doing that. Don't sedate them unless you have to. I had a call, this was about, I think it was probably about eight or 9 years ago now. My night shift therapist, graduate of SJBC, this really smart gal. She called me in the middle of the night, 2:30 in the morning. She said, I cannot get this patient to be synchronous with the ventilator. We have ventilator asynchrony and she's going crazy. What do I do? I said, put him on CPAP. Didn't get a call back. What did that do for that patient? It allowed them to drive the boat. You allow your patient to drive the boat. We don't listen to our patients often enough. They're trying to tell us something. So what do? Sedate them, paralyze them, or at least we used to. And would you like that if you were in their shoes? Probably not. But then we go back to the I would want to be comfortable type thing. So be judicious with both your paralytics and your sedation. Do not ever allow paralytics to be administered without sedation. I have seen two patients that I know of that almost died from fright because an intern gave the patient a paralytic and did not sedate them. You imagine that? You're fully awake, but you've been given a paralytic and you can't move your diaphragm. Boy, that'd get my attention. Yeah, that was a bad scenario. It didn't come out bad, but it wasn't right for the patient. So there's that patient, do no harm thing. I don't know. What other agents do we use in the ICU? Oh, come on, you've had pharmacology, haven't you? How many of you have not had pharmacology? Okay, so just shout them out. Any of the agents. We've already gone over Versed.
Epinephrine.
What'd you say?
Epinephrine.
Epinephrine for sedation? No.
Versed.
I'm sorry, what? Neuro blockers. Okay, but that's not sedation. Right. I'm talking about just for sedation. Same, yeah. Somebody said it over here. Etomidate and then Precedex. Precedex has gained popularity over the last 5 or 6 years. Most of these drugs that we use now in the ICU for sedation and management, where'd they come from? Where did we first start using them? In the OR. They all started in surgery. These were surgical medications. Back then, we used to use Valium a lot. We used to use all the other benzodiazepines. But let's see, what else?
Ketamine.
Sorry?
Ketamine.
Ketamine. Yeah, there's a good one. Ketamine has now regained popularity. It had lost popularity for quite a while because of the emergence reaction in children. Kids were freaking out and having psychotic breaks. I've seen one of those. It was not pretty, and they had to switch to another agent just to calm them down, only to bring them back out. Another thing to consider when you're looking at sedating your patients is if the patient, we mentioned earlier that the patient might have not been entirely truthful about their habits, drug habits, or whatever their substance abuse might be. So what do we do for these patients? Patient comes in, known meth user, and he's in septic shock because he had a cut on his leg and it got septic, and now he's in septic shock and we have to ventilate him. So what do? We ventilate him, and what's the next thing we do? Sedate him. Why do we do that? He's already sedated. He's already pretty much sedated himself. My point is, be careful about reintroducing medications that might be addictive. because you can get into some real trouble. Okay, let's talk a little bit. What else do we want to talk about? Reversal agents. Romazicon is one. What does Romazicon reverse? Benzodiazepines. What reverses opioids? Narcan, naloxone, yes. How much? How much naloxone would you give at a time? 0.5 what? Per kilogram. Right. Yeah. But usually you get 0.5. So these are some things that you need to be aware of. You may not be physically administering these medications. So let's talk a little bit about RTs administering the medications. I did not require my staff to be ACLS certified. How come? Can't push drugs. The information in that is crucial. You have to know your ACLS protocols, but I did not require it as a condition of employment. Most of the RTs took it on their own. The hospital would pay for it, but it was elective. I made it elective, and that's why. Because if they didn't want to do, they'd be held responsible for the content of the ACLS program, but they couldn't push medications, so I didn't make them do that. But it's important, just like in neonatal resuscitation, that's one of the modules. You have to know that module, and you have to know those doses. So it's a good thing to brush up on. If you're another thing that I always tell students is, when you're done with this program, you're going to take a bunch of tests, right? And those tests are going to enable you to achieve a level of practitioner, which is what the P in RCP stands for. In the state of California, that didn't used to be this way. Mr. Najjar and me and others went to the legislation in Sacramento and said, "Hey, we got to raise the bar here. We want to make sure that people who want to apply for an RCP license in the state of California have to be registered first." So now you guys are all going to have to be registered before you achieve licensure for the state. Didn't used to be that way. So what did that do? It raised the bar of quality practitioners. So what I want everybody to remember is what the P is in RCP. It stands for practitioner. Do not make yourself a technician or just a neb jockey. You've gone through this program for a reason, to stimulate your mind to take this into your career. You're launching your career and moving forward. This is important stuff. Again, I digress. What else about procedural sedation and or sedation in the ICU do you not understand or you're having problems with? Anybody?
Just experience.
Huh?
Just experience.
Exactly. That's 90% of what you're going to be doing out there is going to be based on experience, giving you a comfort level. And there's no such thing as a stupid question ever. But if you have questions, best place to ask them is right here, not necessarily at the bedside. Although, depending on your preceptors, how many of you have had preceptors that you really, really liked? How many of you have had preceptors that you probably would not voluntarily go get them again? Yeah, those are the ones we want to talk to, because if it's not a valuable educational experience for you guys, that needs to change. That's not why they're there. So, what else? Nothing. Okay, so let's go outside the arena of capnography, procedural sedation, and ICU sedation.